Volta, and northern regions. So far, those chapters, you'll notice in our brochure, we have the chairs of those chapters are also moved to encourage the regional chapters, the chair, to take it up and also organize activities under the Breast Society of Ghana to encourage many more in your regions to join us. We've also had the committees who have been really working very hard. You will hear from some of them during the business meeting. The Breast Screening and Outreach Committee, Advocacy and Publicity, Research, Finance, and the Organizing Committee have been doing excellently. Without these committees, we won't be able to achieve what we have achieved so far. We've also worked on a strategy review for our 5-year strategic plan. As you know, that was launched earlier. So we are 5 years now this year, and we need to have a plan for the next 5 years. So that has also been done. For October, we have ahead of us a launch and 1,000-man walk. We've started mobilizing people. We want as many as can join us to do so. We already have buy-in from our parliamentarians who are really excited about it. And if we are fortunate enough, we may even have the Speaker of Parliament join us for the walk. So I think this is a call for action for all of us. Let's let the world know what is happening. Let's Ghana know what is happening. And Breast Society of Ghana, our hope is that that will be the umbrella organization for all other organizations. The uniqueness of the Breast Society of Ghana is that we have the professionals who are in all aspects of breast cancer management actually manning this organization. And we also have our survivors who have walked the journey, have been victorious, and are together with us moving this forward. How can you, what better, team can you have to move forward? So I think this is one of the key and the unique things of the Breast Society of Ghana. And as I say this, I'd like to especially recognize Professor Jonas Kleglamte. Prof, please, can you stand for us to see you? You have been amazing. That's the father of Breast Society of Ghana. Thank you very much, Prof, for the vision, which you didn't keep in your head, but you actually came out, brought a team together, and this is how far the Lord has brought us. God bless you richly. So our focus and our core mission is to provide coordinated medical, allied health, and social interventions for improving standards and outcomes of breast care. Coordinated, allied health, and social interventions. So all of that together. We are hoping that each and every one of us will come on board, support us, and help us achieve this goal. As we embark on this exciting, knowledge-filled, soul-inspiring 2-day journey, full of scientific and policy-informing presentations, much of which we have had yesterday. For those of us who were here, those who were not, some joined us online. We had very interesting panel discussions, presentations, and panel discussions, looking at key issues, the patient journey, the equitable resources within the country, and financing in breast cancer. And we had some of our key stakeholders here to actually discuss these points. A lot of them have come on board. In fact, the Speaker of Parliament has promised to sign the communique that we are going to give to them on what has happened now. We have been also invited by the Female Caucus to join them in Parliament at some point to discuss this. So we think we'll move forward. I'm sure once that happens, the Ministry of Health and the Ghana Health Service will also come on board for us to achieve this. So thank you very much for coming from far and wide to be part of our AGM. Make new friends, collaborate, joint action for breast care. Together, we can reach greater heights. The future is bright. Thank you.
Madam President, Tuaso. So, like the President said, we actually appreciate our council members They've given us the direction and everything. And they have also made it possible for us to be here and for us to raise the standard this year. 2 day, maybe next year we'll go 3 day, and we'll start going to the regions. So we are going. So I'll now invite our able-bodied council chair, Mr. Charles Fojo, to come and give us his presentation.
Thank you. I didn't bring the book because the thought has changed. So what I've written down is different from what I intend to say, because what we saw yesterday and some of the evidence that we got after the meeting in talking to other people about it shows that the future is now. And if we are celebrating, if we are 6, then that means that by the time we are 10, that is just like the next 5 years. So how Ghana breast care management will look like by the time we are 10 years depends on what we start doing from now. And as Hannah rightly said, what Prof and the pioneers have started for the past 6 years has moved us so fast, up to from a team of less than 20 to this big team to 230 something, to now doing a 2-day, and now where we are now. So effective now, we need to set an ambition that by the time we celebrate 10 years, the management of breast cancer in Ghana should be as close to what is in the developed world as possible. So that means that the responsibility of Breast Society of Ghana has to move from where we gather because we are professionals and we are bringing in survivors, to look inward and talk about us, to talk about how we become the catalyst. We become the catalyst to catalyze the atmosphere out there to become like the developed world. I was amazed yesterday, 2 people. The solutions that we talked about all day here, the people are just waiting to do for us, but nobody has come to sit down and talk to them. They said, is it another thing? So until you come to access, we will not be able to do it for you. I was telling Prof this morning that I was told that the Ghana has, since the days of President Kufuor, has been on sugar. That's, but because nobody in healthcare has asked the minister for her to use what this can help her, that money is in the other things, but not healthcare. So they tell us. So that means that the breast society and how we do has to change effective today. That means that we need to look at our strategic plan, and because I've had the honor of seeing it, I know that it is very ambitious and transformational. We need to do it. And we need to have a quick mindset change that it is our responsibility to go and ask for it. Nobody will come to us. So now we need to move. We need to see how we catalyze and create the table and bring the stakeholders to do it. Which means that we cannot do it alone. Because we need money. If you want to bring in the NHIA, all those across, it cannot be in an office. It has to be somewhere in a good ambience, and you need to talk. If you have to invite our members and bring some from the north, bring Gatika and people to come and talk about, you need to do it differently. I listened to the stories yesterday, and because project with Ross, I've had enough to tell their story. So different. We train all patients in terms of tell their story from my social, economic, all perspectives, to make the story compelling, so that by the time this person who needs to give you the favor will say, wow, this is it. We need to do, and it needs money. It is not the deals 100 that will do it. So that means that we need the industry will only give us the money if we are attractive. The only comfortable with this, when they know that we have a clear plan. So we have the opportunity today, as we meet here and we are reviewing our constitution, to reflect that 10-year mindset of in 10 years, this is how Ghana should look like. And therefore, the composition, the membership, need to look like. This is how survivors should be encouraged to do. We have to get to a point where no woman in Ghana with breast cancer loses a job because the person cannot go to work. It should not be possible that there has to be that emotional factor that people deliberately come to look for them and employ them so that they can get money to eat. Because we have created breast society, because we made breast society so attractive and so compelling that everybody wants to be with us. It has to be so attractive that every corporate body will want to have logo. That is what in which we do. So please, it should not be business as usual today, especially when we are doing the constitutional review, in the selection of leaders, and the way that we go forward, and then the commitment in what we do. So I will encourage all of us. Tea is nice, apple is nice, but this is more important. Spend more time here today, and let us deliberate together, so that by the time we finish, I've seen the draft communique that we had. Obviously, we need to change it. The communique has to be so compelling and so moving that when we talk about it and we show it to anybody, they will see the change and the movement that needs to do. I believe that myself and our council members are more committed and willing to support the executive support. And I believe everybody here would do it, because if we don't do it, nobody will do it for us. In 10 years, let us meet and have a 10,000 event where 10,000 people are seated in the room because of the impact that we've achieved in the journey that we are going to do. We believe it can be done because American Cancer Society has done it. All the cancer societies as well have done it. And we can do it because we have the right people in the room. Thank you.
Thank you so much, Council Chair. So Council Chair has set the ball rolling. We now know that ask and you receive, seek and you find, knock and the door will be open. So we must ask, seek and knock. You see, I'm looking at MSD. Yeah. So this brings us to the end of the first session, and a few announcements here. There are iPads in the lobby, so this can be done during the break times, where you can just press on it and listen to stories of survivors and the likes. So there are iPads in the lobby, so anytime there is break, you can easily go there. And then for the first time, we are doing parallel sessions. That's why I said we should refer to pages 16 and 17 of our conference booklet. So we will break it into 2 sessions. So the first session is in Ankobra, and this room is Ankobra. So you can see the 4 talks there. The first by Mary Idrisu. Then the second will be by Brenda. She will be presenting from New York. And the third by Sandra, and the fourth by Kwame Dako. So anybody who is interested in these topics should stay in this room. The next room is Birim. Birim is next to the washroom. I'm sure everybody knows where the washroom is. Pass the washroom and then the door to your left. That's where Birim is. And then over there, Morris, Christian, Naomi, and Rita will present their presentations. So again, if you are interested in these topics, you can move there. I've just been informed that the talk by Kwame Dako, that is the 4th talk, the breast reconstruction talk, almost everybody would like to listen to it. So we will make a slight adjustment. After the 3rd talk here, we will do some question time, maybe 10-minute question time for those to finish. So by the time they finish, then they can come here and listen to Kwame's talk. Because I hear everybody says, a lot of people says they want to be at both places at the same time. So yeah, and also you can, depending on what you want to listen, you can just move around. But the fourth talk would delay a little bit so that almost everybody will be able to listen to it. So it's time for us to break into our power sessions. The chairman for this talk will be Ebenezer, and the other talk will be Reverend Mrs. Josephine. So please, you are free now to move to whichever you want to listen, and then we can start with the power sessions. Thank you so much, and thank you all for being here. So just continue on and then left. The, everything is set up, and I'll be shuttling between the two rooms. Ebenezer, the mic is yours. Door is locked. We didn't want people coming in. So, depending on your interest, you are free to move. I'm not here. Okay.
I think we can use the next 5 minutes to settle so that we start at 10. So we are left with 3 minutes to 10. So maybe we can have some discussions on a few ground rules that we can run smoothly. Yes. So please our speakers. Yeah. Um, I understand. Can speak. Yeah. Okay. So we will be having three presentations, just as Boss Akwasi mentioned. The fourth presentation, because we would want to have it as a combo, we would wait for the other members to join us. So each presentation would run for 15 minutes. Yeah, that's very important to me. Yeah. So each presentation is expected to run for 15 minutes, right? 12. My boss is saying we should do 12. Okay. Ah, all right. So let's do this. Up to 15 minutes. It satisfies both sides, right? Yeah. So we will run each presentation for 12 to 15 minutes, and then after all the presentations, then we can have the Q&A as we wait for the team to join. So as we are much aware that we'll be discussing or we'll be receiving various presentations which are more or less scientific presentations, our focus as BSoG members, as members interested in science, will be moving around when the study is to breast care on our continent and beyond, um, how the work was done, because maybe somebody will be interested in replicating the study somewhere else in the facility. And we'll also be focusing on the major findings and what we can take from the study that was done. So for our Q&A, I'm very grateful if you could focus on these four areas. Well, it's allowed to go out of these four, but if we stay within these four, I'm sure we will get a lot from that. And then our speakers, their contacts and how to get them are in the brochure, so you can always reach them with any questions or any collaboration or engagement you wish to have. So it's 10. My name is Ebenezer Wiafe. I belong to the Department of Pharmacy Practice of the University of Health and Allied Sciences. And our first presentation will be from Mary Idrisu. I saw her in our facility some time ago, I think last year. I'm sure she was doing this study at that time. Yeah, I also serve on the ethics committee, so I I, I remember seeing this study. So Mary will be helping us to embrace the care of breast cancer in Ghana. Thank you, Mary. You have 12 to 15 minutes.
Thank you very much. If I get the opportunity to change the topic, I would say the journey of the provider, like what happened yesterday. So I'm talking about embracing. Okay, okay. Thank you very much. So, all right, all right. Thank you very much. I've been given extra duty. All right. So I said if I were to give I were to be given a chance to change the topic, I would have said the journey of the provider as it happened yesterday. So my topic is embracing the stories of care, an ethnographic insight into factors influencing breast cancer care. The import of the study, this a study, a paper teased out of a bigger study that sought to develop a navigation program for breast cancer care in Ghana. I think your cursor isn't moving. Okay, great. Thank you very much. Sorry. Sorry, I think, yeah. Okay. All right. Thank you very much. So, by way of introduction, we are all aware that breast cancer is causing a lot of harm and is leaving behind maternal orphans. And we are also aware that in Ghana in the year 2020, breast cancer, out of the number of breast cancer cases diagnosed, about half of them died. And then research has also shown that cases of breast cancers reported in Ghana are reported in the late stages. And we are also aware of the limited resources that we find in the country. And all these things are also affecting the carers who are providing care to these patients. So the import of the study I think I'm trying to move it. Yes, it isn't moving. Hello. Yes. It isn't moving. It's going back. Yes. Okay. Thank you. So we have to go back. All right. Thank you very much. So I use the multi-level framework to inform the study because I look at the factors influencing breast cancer care from the patient in the center to the policy decision makers. This particular findings is coming from what the healthcare providers factors were. So 4 objectives guided the study. So the first one was reviewing literature on existing navigation programs. The second one was exploring the factors influencing breast cancer care among the individual, the community, the survivor, and the family. Then the third one, which the focus of this presentation is on, is the factors influencing breast cancer care among the healthcare professionals. Then the development of the navigation program. So methodology, I use a focused ethnography, which afforded me to be able to explore the factors in an ethnographic way to understand the culture, to go and live with them, to observe and see what is happening. So I use 5 facilities within 4 regions. So I use the Tamale Teaching Hospital, the Ho Teaching Hospital, the 37 Military Hospital, the Eastern Regional Hospital, and then the Greater Accra Regional Hospital. My interests were healthcare providers who were giving direct care to patients. So I use purposive sampling, maximum variation purposive sampling. So I purposively went and selected people who were directly caring for these people, and I selected varied people within the healthcare setting. And again, my interests were nurses, doctors, pharmacists, pathologists, consultants, and then laboratory technicians or scientists. Then I excluded people who were new in the facility and those who were on rotation. Those people were excluded from the study. How I analyzed my data, I collected the data I analyzed. I used individual, in-person, individual or telephone interviews. I also did observation and I also did document review. Then, in terms of analysis, I used 2 approaches. I used Bradley's 3-step approach and I also used Fry's 7-step approach of thematic content analysis. It sounds more scientific. Please don't worry, we'll get there. So you see me in the facility to go and work with them to observe what is happening, to be familiar with what is already existing. So these were some of the things I was doing. I was participating and also observing as a researcher. So in terms of the data quality, I allowed Johnson et al.'s 2020's 5-step approach to guide me from the topic to the conclusion of the study. And then ethical approval, I had ethics approval from 4 ethics committees. 37 Military Hospital, the Ghana Health Service Whole Teaching Hospital, and then the Tamale Teaching Hospital. In terms of the people I interviewed, this is a pictorial evidence of the people who were interviewed for this particular study with regards to the healthcare professionals. So nurses, doctors, nurses, or doctors were having issues. And then I also had provider competency. And these were bordering around evidence-based practice in screening and diagnosis. And also patient-centered care and communication strategies. Then I had advanced case management stress because the cases going over there were in advanced stages. We had clinical decision-making emotional toll on these healthcare professionals. And again, workload. Then I had issues bordering perceived chemotherapy effects. The ladies giving the chemotherapy feel, if I continue to stay there, I might not be able to give birth in future. And then I've heard stories of others having problems, and I may also go through. So the area was also, they were also stigmatized in a way, and not the patient alone. Then when it comes to motivation and commitment, there were issues. Now let's get to the intricacies of the issue and see. So we find quotes as in terms of multidisciplinary team relationship. So somebody saying, there is no connection between the doctors in Accra and we here. When we manage cases and we send to Accra, they will sit there with all the privileges they've gotten with respect to resources and be criticizing us without finding out from us what is happening to us at the countryside. Then somebody said, even yesterday, I fought with one doctor. Why will you remove a lamp and throw it away when you know that the protocol says every lamp must be sent to the lab? And they will also direct cases to unapproved places when you know that such centers have integrity issues. Then when it comes to provider competency, there are people who were palpating lamps and they were saying that this particular lamp is very soft, and for that matter, it's not breast cancer. The cancerous ones are hard, without allowing the patient to go through the protocol to be able to diagnose the patient. And somebody said, we just recently had a workshop. The person is in the chemo unit, but has not gone through any training. The only training the person has received is with respect to tissue sampling, how to take tissue. Meanwhile, the person is not an oncology nurse and hasn't gone through any training. Then with respect to perceived chemotherapy effect, somebody said, I heard that if you are a lady and you work in such areas, you can't give birth. And I also heard that if you get into contact with cytotoxic medications, you will get cancer. That is what I know. And this is what is deterring them from going there. So advanced case management. At times we feel nurses or maybe the healthcare professionals are not friendly. When I went to the center, I realized that these were the reasons. They feel that when they bond too much with the patient and the patients die, they have emotional toll. So they kind of create a barrier. So somebody said, because they report late with fungating wounds, their wounds cannot heal, and we normally lose a lot of them. The stress of seeing some of them die is unbearable, and we can only encourage ourselves to be strong. Then this person said, it's sad to care for a patient only to hear she's dead. Personally, my prayer has been that no patient should die in my presence, but unfortunately, they die, and it's actually affecting them. Then let's see, motivation and commitment. We aren't supposed to be walking around looking for food. So they work within the chemo units and they don't have even water supply to them. So they have to walk, look for food, come and sit within and eat because there is no place for them. So it's everywhere. That is where they sit and do everything. And somebody said, nobody comes to say, well done, because management feels it is your responsibility and you are being paid for rendering such service. And somebody I remember said, they only come here when they have their family members here or when they know that media is here, so they will get media coverage. These are the stories of the providers. And I feel that it's the stories that we must embrace them. And other studies have also confirmed some of these things. But one interesting thing is I didn't find a study that was talking about providers maybe having relationship issues. But then they were thinking that some providers have issues because they were carrying home issues to the workplace, but not maybe having institutional issues or maybe professional issues. Now, the study has some recommendations. In conclusion, I said that the healthcare providers have also issues that borders around breast cancer care. And that when we are able to train people, we increase the training on specialists, it will help. And then staff motivation, because some people are able to communicate and they will tell you, even in Kolebu, we know that this percentage of people's salaries are given to them as incentive, and that's why they continue to be there. Here, even water you won't get. And somebody said, it is not even in their dictionary. There were a whole lot of things. So we feel that staff must be motivated. If I've committed my life to stay there and give chemo, then you need to motivate me to gain my commitments. Then we come to mentoring of staff in the district and sub-district. So if they refer the cases to us, it's a plea, and we realize that they are not following the protocol, then if we don't have the time to maybe the chance to train them formally, then we can mentor them as to how to do things. Even through these telemedicine issues, we can do that. Then psychological care of staff. We realize that we've heard a lot about the patient stories. The staff, they're also going through a lot. When you meet the person has frowned the face. It might not be that the person doesn't want to be closer to you, but the person is a human being. Inwardly, they're also going through a lot. And I feel that the duty bearers must also look at the carer so that the carer doesn't break down. So these are a few references. I acknowledge my supervisors, Professor Lydia Aziato, Dr. Gladys Johnsey, Banga, Carnegie, for thesis completion grant that they gave to me. And then I also, all the institutions that allowed me, it's not easy studying, an institution, because CEOs, consultants, they allowed me, I was so overwhelmed. And then they listened to me. And then the Breast Society of Ghana for sharing this piece with you. I have a lot of data. And I know that anywhere I hear that they are doing some of these things, I will definitely share it. So, thank you very much.
Thank you, Mary. Accra, the Accra bosses, president, my mother. You see, we are sending you a message. Oh. You are in Accra, and then when we do that thing and we send to you, then. So many interesting signals have been sent to Accra. I think we would need IT's assistance in getting the second speaker on. Yeah, Brenda. Yeah. Yes, please. Yes, please. So, we know traditionally it's our mothers who run thing. Some time ago, I heard that they are actually holding the economy. If you go to the markets, they are keeping the things running. So, looking at this study title, we are finding a way to empower our mothers to continue to heal the country. So, I wait for the IT guys to put things in place so that Brenda can, make her presentation. We should be thinking about our mothers, and the more reason why we have to work so hard to ensure that they get the best out of the services we render in our health facilities. Although men also get the disease, but we all know that the percentage. Since 2019 that I finished my first degree, I've seen only 2 men with the disease and a lot of women almost every day. So Brenda is going to help us so that we can understand some of the issues with the care and how we can empower our mothers to heal Ghana. Thank you. All right. So 18. I yeah. There we go. The mic is she on? Just a few minutes. Okay. Okay. Oh, and I'm seeing that Brenda's work also took some cultural consideration into the design of the study. I mean, and she's oh oh
Well,
welcome.
can you hear me?
Yes,
I can
yes.
hear and
Hello.
see you.
Yes,
Well, can you hear me?
yes,
I can
yes.
hear and see
Welcome.
you.
Yes,
Can you
yes.
hear and see you? Can you 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 hear and see you Please, are you going to share my
always try out call it. Mom is a cancer survival, and as part of the treatment, she had surgery. And after her surgery, we thought we were done. And then moving forward, right after surgery, she started having what is shown in the picture. If you look at the picture, you see a disparity um, in the breast. And what was this? She was told that this is, and we aspirated it the first time. We recollected. Now it started scaring her. Hey, is the cancer still there? Hey, what pains am I feeling in this thing? And anytime she goes, the needle pricks that she gets, and the fluid that comes out was just a big bother for her. And I can tell you that this is actually a very big bother for all other women who have breast cancer surgery. Either you do a mastectomy or you do a breast conservation. This is actually a big problem for them. And so these are the concerns of most women. And aside it being a problem, it increases their morbidity. It takes them away from their usual work. And imagine you have to be going to the hospital every time to have this aspirated. Look at our financial state in this country. You need to board a car and all the burden that comes with it. Is actually a big bother for women. So as a surgeon and as someone who will be operating on people with these conditions, I thought that what can I do to actually help improve, if not reduce the rate of seroma formation. So there's been a lot of research about seroma, and what came out was that, yeah, I've skipped one slide. What came out was that a lot of research has been done, and the theory is that seroma actually occurs because of inflammation after surgery. If you see, that's the fluid you are draining from the swelling that you saw on the woman's chest. And so, since it is an inflammatory process, why don't we use something that would help reduce inflammation to see if we can actually stop this process from happening, or even reduce it, if not stop it entirely. So we decided to use steroids since an anti-inflammatory medication, to introduce this during surgery to see if it would help reduce the rate or reduce the volume of fluid that accumulates after surgery. So how did we go about this? We got ethical clearance. We consented 142 patients coming for breast cancer surgery, either wide local or mastectomy. We excluded men, pregnant women, or those who have reconstruction, because they may have other variables that may make analysis a bit difficult. So we had 142 patients, and we randomized them into either arms. The first arm were those that got the medication, and then the other arm were those that did not get the medication. It was actually a double-blinded study. So those who were giving the medication were not aware, and those who were administering the medications were also not aware of who they were giving the medication to. This is just to reduce the bias during analysis. And we followed these patients up to 90 days after the operation. And as part of data, we also took some clinical pathological data so that we can make some inferences from whatever we get. And so the results, briefly. So what we got was that this is just a general data from the patient, the clinical data from the patient. If you look at it, the error bar just shows that majority of them were really comparable, even looking at the interventional group and the control group. So whatever variables we get, we can look and compare and then know that they are similar. So the age is probably just around the same, 40 to about 70 years old. If you look at the BMI, it's just around, most of our women, we are obese anyway, so it's just around the same area. The comorbidities that they have, diabetes, hypertension, these are the usual things, and these are part of the things that when we are managing patients with breast cancer, we would also know they have. So interestingly, So interestingly, the incident that we got of seroma. So I've written the aims of the study at the top, and to see whether the results we got were able to achieve those aims. So one of the aims was to determine the incidence of seroma after breast cancer, and also to see this incidence with respect to the treatment that we put in place. So when you look at it, the total just tells us that our seroma rate was as high as 95.7%, meaning almost every woman that had breast cancer surgery would end up with a seroma one way or the other. Just a few of them didn't really get the seroma. And when you look at the intervention and the control group, the numbers are just about the same. And definitely wasn't significant. So the using the drug didn't really make any difference in who was getting seroma or who was not going to get seroma. But interestingly, this follow-up up to 90 days. Interestingly, this follow-up up to 90 days is very important. And wanted to determine the incidence of seroma after breast cancer surgery, and then to determine the incidence of seroma using the drug. So when you look on the chart, the pointer doesn't work. When you look on the chart, majority of the people with breast cancer, who has had breast cancer, who gets surgery, would have their seroma from within a week after they have been discharged and the drain has been removed. So within a week, most of them would come back with seroma. And when you look at it, by 30-day follow-up, the numbers that we had, which was 95 or so, would have dropped to about 50. And so that shows you that with time, the seroma actually resolves. And then by day 60, further reduction in the number of people who will get seroma. And by day 90, almost everyone would have a resolution of the seroma. And when you look at the curve, you can see that there is no separation of the curves, meaning that there was no real difference in the medication that was used. So basically, everybody just follows the usual curve. Then we also wanted to determine the volume of seroma that was drained and the frequency of aspiration in the patients that had seroma. And we realized that, interestingly, the intervention group, those that we gave the medication, actually had more seroma drained than those who did not get the medication. And the possible explanation we thought maybe there was a rebound inflammatory after we gave medication to suppress the inflammation. The body had a rebound reaction by worsening or getting more inflamed and then causing more fluid to be produced. And then when we look at the number of times, because this has a financial implication on the patient, and we realize that majority of them will come about 6 to 7 times after the wound has healed to have seroma drained, and that's quite significant. But we'll see what we can do about that. And then we also studied the clinical pathological factors that we took. We wanted to see how they relate to seroma, whether you have any that would increase your risks of getting seroma. We actually looked at 17 variables, and to be frank, only 2 were found to be significant, and these were the receptor status of the patient. And we think this became significant because majority of the patients actually had ER and PR positive. And so in literature, there's actually been no data to support the fact that the hormone receptor status has an effect on your rate of seroma formation. So the implications that this study has brought to light is that the results do not support the theory that giving intravenous steroids reduce the rate of seroma formation. Nevertheless, it is important for us to realize that with time, if you have the seroma with time, it will definitely do what? Resolve, even though we have outliers who would go about a year like my mom for it to resolve. And also, neither patient-specific factors. You don't have anything that's making you get the seroma, or the surgeon has done something wrong, that's why you are getting the seroma formation. And then of note is that the receptor status may be to help reduce seroma rates. So it's something that in the future we can look at and see how best we can use that to help assess whether we can reduce the rate of seroma formation. So in conclusion, my take-home message is that we can now even confidently counsel clients that the seroma that you are having, it would resolve. It may take time. The way we are all different, we all react differently to things. So just be assured that with time it will resolve, and you should just take heart and take it as part of the journey of the breast cancer treatment. Thank you very much. Conclusion.
Thank you, Sandra. We have our third parliamentarian with us, so we'll be grateful if he could say a few words.
Today, the number is down. Oh, okay. Our coming here is to demonstrate our commitment to ensuring that this cancer issue is over. I had to pass somewhere before coming to this place. You know, we have a lot of work to do. So I had to pass one place before coming here. That is why I am late. So I apologize for being late. I was, in fact, I showed a lot of interest in this presentation. And I told, what is it? Regional, that I should get copies for us to be looking at, especially on the part of funding, so that when we get there, we'll be looking for cancer support in the budget. So I wish you well. We'll be with you to the end, and we are sure that our participation will bring some interesting story at the end of the day. Thank you so much.
Number your name.
Well, because I have not mentioned my name because I was here with you yesterday and I participated fully yesterday. My name is Alexander Gabi Hotoja. I come from Mafikumasi in the Volta region. The person seated there is my aunt, the one behind Dr. Josephine. She is my aunt, and I come from Volta region. I'm the MP for Central Town and a member of the Health Committee of Parliament.
Thank you, Honorable. So we would have to engage our presenters on some questions, and then as they try to address these questions, we also try to join hands in addressing the questions with them. It's teamwork. Okay, Mary. Sandra? Yes, please come. There are some wonderful chairs are here for you. Yeah, I'm not sitting with them. So this second mic going around for the questions. So maybe we can start with Mary. Yeah.
Sorry, my name is Prince. I'm from Pharmacy Symbiosis. I'm a pharmacist. Yeah. My first question to the first presentation. So you talked about perceived chemotherapy effects. I was looking and not actual. And then the second one, you mentioned that some of the effects they think about is the fact that they can't give birth and they can also get cancer, which is not perceived. It is actual. Though the risk is low, it is not negligible. So why didn't you address it? In that sense. Yeah, that's the first question for. Yeah, that.
Okay. Maybe we could. only to Mary, or you have one question from Mary, right? So, Mary, would you want to take? Yeah. So go ahead, please.
All right. Thank you very much for the question. So when it comes to the pharmacist that I met, so in the facilities, it's not all the facilities that you have a pharmacist being there. And then one facility that I found a pharmacist, the pharmacist will reconstitute the drug. They have their own place with the biosafety cap. They reconstitute the medications, and then they have a box, a window. So they push the drug there and they hit. So the nurses will come for the medication. So they don't even come to the chamber where the medications are being administered. There is one place I found a pharmacist. He will come, bring the medication there, and then he leaves. They don't stay there. It is the nurses who stay there. I made it perceive because he realized that in all the themes, I wasn't too the negative. So I play that advocate, whether it's positive or it's negative. So yes, we know that the effects are there, but this is what they are perceiving. For example, somebody says somebody developed a brain cancer. We can't say that the person had the cancer because the person was living or working in the unit. It could be that this person was having this cancer, but then probably when he came there, that was when it became evident. So we can't say that working there was what was actually brought about that particular cancer. That's how it's name perceived.
Okay.
I don't know whether you are convinced with mine. All right. Thank you.
So that the argument Mary is making is also one argument some policymakers also could make, especially when you're talking about risk allowance, and you are, hitting on these things that you may have this cancer, you may have a cancer because of it. He may tell you that maybe you already have the risk. It's not even the medication you are working with. But although it's perceived, it's actually real. It's actually real, but then it's perceived. So it's exactly. So that is where the policymakers also hit on. So it's a call to us to do more studies, trying to give them the figures. Because if you realize during Mary's presentation, she mentioned remuneration, and
Yes.
those things. So although in books we are picking the signals that people who worked there for some years got this and that, somebody could tell you that I've been preparing the medications and my hair has been going. But until we pay attention to the figures and really have it out as well, or play around these things and say it's perceived and all that.
Okay, so if I may come in again, Mr. Fojo will tell you that last year AGM I was following him, because when I went around the facilities, I went to a particular facility, 2 beds, and then they don't have even incubator, an old incubator to reconstitute these medications, and the person doing it is not has not been trained on the job. So this person is doing it because the person wants a permanent employment. And then a nurse also came who was also trained. And this particular nurse is also reconstituting the medication. The pharmacists have left themselves, they've taken themselves out. They are saying that until the facility gets a biosafety cap, they will not expose themselves to the medications. And the medications are right reconstituted there. And they stay there. And you can just imagine. Yesterday I went to Mr. Fojo again, and he said I should see Reginald today for us to discuss about this. These are the realities. And then the nurses they say they cannot even measure their toxicity levels. So you see them drinking lemon juice, and they are taking nice meal. I was there, they bought some for me, I ate because I was working with them. And then they said, when you go home, take lemon. I said, okay, that is the culture there. So it's reality. Thank you.
Yeah, when Prof would like to say a few things.
Well, I was just going to say that don't blame Mary. I mean, she's looking at people's experiences. But if you want the hard facts whether or not it's actually happening, then that's not the type of study that will show that. So then you need a quantitative study.
Thank you, Prof.
Thank you, Prof. And the equipment is very expensive. We are looking about the 300s and the 400,000s, just to buy that equipment. So we are talking about big money. Yeah.
My name is Doris Sador. I'm from NHIA. My question is not part of your it's not part of your objective, but I just want to know, as you were taking your data, are you able to tell whether healthcare providers were aware if breast cancer treatment costs is reimbursed by NHIA?
Thank you very much. So, I would say that yes and no. So, yes, some people think yes, it's covered by national health insurance. Sorry. But then there is what we call co-payment. There are facilities that when you go, they tell you that this medication costs this amount. We have purchased the best for you. This is the amount health insurance pays. Because we want the best for you, you must top up. That is a co-payment. There were some facilities, the patient is told that insurance covers, but we don't have it. So you go out and then you buy. There were some facilities, the patient is told, bring your health insurance card. They take the health insurance card, they register you all right, and they tell you insurance only covers for the consultation. There were some facilities, somebody went through surgery, paid for everything. When she was about to be discharged, she told the nurse, I have national health insurance. And he said, here it doesn't cover. So yesterday, what the question I asked was the tip of the iceberg. There are more. But I think that at a point in time, I also saw that my life is also very important. I was being too intrusive. So I also, I kept myself somewhere because that was what led me to go and interview national health insurance managers in the regions. Because what I saw on the floor was different. Because we said insurance isn't working. Then I realized that most of the problems were also coming from the providers. Because I take your national health insurance card and then I register you. It means that when it is time for me to go, I'll claim it. But then I ask the patient to pay. And then the patient is told that if you have a complaint, there is a short code. I think 4 digits are forgotten. 4 digits, call National Health Insurance and complain. And then the patient feel, if I call and they send my name to that hospital, they will not give me care. If it's me, I won't do it because I want to be fine. Why will I go and report my provider? So I'm thinking that if health insurance wants to know the truth on the field, please send people out there to act at patients or send patients. We are not saying that go and prostrate for providers, but these are the realities. When you go through everything successfully, but then send somebody who doesn't know anything. And we can also complain. That is the reality there. Thank you.
Please, quick one on this health insurance issue. You see, what you are saying is true from what you saw. But then people, let me put in quotes, misbehave when the system is not perfect. If it's covered by insurance and no pharmacy wants to sell to you because they won't be reimbursed, then people start inventing ways and means. So I think they have health insurance also need to review and see what they are doing. I mean, you are reimbursing somebody 6 months later, 9 months later. The amount you are reimbursing can't buy the chemo. Your best bet is some inferior chemo full of nothing. So your provider may be helping you, even telling you that, I'm sorry, the drug is not available on insurance, go and buy. Then they'll make you go and buy the proper one for your own good. So it both ways. But I just wanted to comment. Thank you for bringing out the issue that health workers also, we face psychological issues. You work with cancer patients, and when you get too close, you're losing patients all the time. We're also human beings. So sometimes you want to distance yourself, be more factual, and then sometimes do patients perceive this as you are not nice, you are cold, but you also have a heart. You come to my ward, you start ward rounds with vim, and then by the end of the ward rounds,
You know, we see our sisters dying from a disease. I know sometimes health workers have been a little impatient and upset. You came a year ago, and then you disappeared. Now you are gasping. It's also not easy for us. Brenda's presentation was also great, an intervention for spouses. We've forgotten all about the spouses, and I've had a couple fighting in the consulting room. You know, the man doesn't understand everything that the woman is going through. The woman too has forgotten that her disease is affecting the quality of life of her husband. So I think Brenda's intervention was great. Perhaps healthcare workers also need a similar intervention to help us keep sane. You know, I think all the presentations have been great.
Thank you.
Yeah, some more questions, Prof.
Looks like I'm more of a defender of national health insurance than they themselves. You see, they about not even paying the right amount. You know, national health insurance is doing a tariff review this year. They've been going through a process, and so they need to even know how much the services that we offer cost, the real cost. And you won't believe it. A major, this one I'll say, a major hospital like Oluwatoshi Hospital is refusing to give them the figures. So how are they going to give you the correct amount? So, like we always say, it's a joint effort. We all have to put in our bits. Otherwise, we can't blame them.
Yeah, please, more questions? Okay.
Thank you very much for the presentations. I would like to know, particularly with the presentation from, I think, Brenda on the helping her heal. Just last week, I had an experience where I'm developing a proposal for an oil company on supporting women with breast cancer. And in my haste, I had a lot of things on my table, so I pushed it to a colleague of mine to please review it for me. And he did. And he came back, he prompted me that I've put a paragraph in red. And he was speaking about his own experience as a son to a mother who was undergoing treatment and the impact on his life. So I would like to know whether we can use the same helping her heal. We can just go beyond the husbands and look at male caregivers. It could be their brothers, their uncles, or somebody, but who are directly also part of their caregiving, so that we can also give them this kind of support. Is it possible? Because it's a research, I want to know whether you can kind of translate it for those who are not spouses but are equally critical in their healing.
Okay, so Brenda delivered her presentation online, but I can tell you that it can be done. There's actually a theory surrounding that we call the attachment theory. So anybody who is attached to the patient, there is a potential that we can look at that space and find some sort of support. So maybe BSoG research committee could pick that up and look at the kind of linkages that exist between these attachments and, you know, build something from there. Yeah. It's a nice research idea. We pick it up. Thank you. Please, any more questions? We can pick maximum. Okay.
Okay, so next question to the presenter online. How would she answer? The presenter online. Yes, please. Yeah, Brenda. I'm asking if you'll be able to answer. Okay. Yeah, so I think in one of the tables that you showed, you talked about the fact that before the intervention of the HHH Ghana, the Help Her Heal Ghana, there was any at the treatment side. But then after they received treatment at varying degrees. I want to know the time that data was collected. Was it before treatment was discussed with them, or it was after it was discussed with them, but then they hadn't gone through the HHH Ghana? And also I want to know if there is patient education and then carer education before, during, and after treatment, or is the HHH Ghana that is introducing that? Because I know that even if it is not breast cancer, for every treatment at all, you have to discuss with the patient for and then after the treatment.
Okay, so I'm sure Brenda picked the question. Once she gets the answer, we're going to read it out to you. Thank you. Let's go on.
Kwame, somebody left this in the other room. Okay. So the hotel is actually asked come for the break, and I'm sure the sugar level is low. But we'll listen to Kwame's own, and then we can go for the break. There's a question time after the sponsors talk, so we can merge all questions then. We are doing Kwame's talk, and then we go for break, and then come back to the sponsors, and then by the time we would have finished everything. Kwame's own. People are ready, so hope you'll be straight to the point. Stay with you. 50 minutes.
Very much. Good morning, everyone, and it's an honor to be standing in front of all of you, smiley face today. How do I use this? The top one. Can we go to the first slide, please? It's vibrating, but it's not. All right. So next, I'll just ask for next slide. Okay, good. All right, thank you. So my name is Kwame Dako. I'm a plastic surgeon. I work at the National Reconstructive Plastic Surgery and Burns Unit within the Kolebu Teaching Hospital. I work close with surgeons, oncologists, radiologists. We're all part of the breast cancer MDT, so we talk a lot and do a lot of cases together when indicated. Okay. So I just want to read a few definitions because they are different. They sound the same, but they are different. So when we talk about breast reconstruction, it's the surgical process of rebuilding the shape and look of the breast. Can we go back to the first slide? Yes, and then we, under this umbrella, we talk about breast conservation surgery. Now, with breast conservation surgery, your aim is not to remold or reshape the breast. The idea is to take off only the portion of the breast that is affected, leaving the rest behind. Now, when we talk about oncoplastic surgery, we're talking about taking off only the part of the breast which is affected, but then remolding or remodeling the breast to try and make it look as normal as possible. So these are different procedures. So next slide. Okay. So why reconstruction? I mean, a lot of women, I'm not a woman, but I'm speaking on behalf of women, would say that it's a major sign of their femininity. Many would also talk about their hair, but we're talking about the breast today, and that is one major sign that, or look that people or women believe makes them look and feel like a woman. So it's a very difficult decision to say, well, there's something there, just take off your breast and end of story. And different papers have come out. My references are a bit too small, but one of them is actually a reference by Prof. Clegg Lamptey, and it talks about women, the fear of mastectomy, and it can be quite a daunting task, a daunting thought, and a fearful thought to have to take off your breast and know that that's the end of it. Based on this, in many parts of the world today, breast reconstruction is an integral part of the consultation. It's an integral part of the treatment. It just doesn't end with the mastectomy or wide local excision or whatever it may be. It's an integral part, just as chemo or radiotherapy is an integral part of the treatment and care. Next slide. So what's the goal of breast reconstruction? It aims to reconstruct what we would describe as a breast mound, and then in some cases also add a nipple if the nipple and areola was also taken off, and to reduce the morbidity of scarring on the patient as much as possible, or hide the scars as much as possible. This has a significant effect on some of the clothes you can wear, some of the ability to buy a bra, and some of the activities you can do, because some of the breast molds, the what do you call those things, the prosthesis, it's just not the same. It's just not the same. Next slide. Okay, so there's a strict selection criteria. Not everyone would be amenable to breast reconstruction immediately. So we need to assess all this criteria that I've listed on the screen, the imaging, the size of the tumor, the grade, stage. Will there be what we'd call adjuvant care, radiotherapy after? And one of the most important things in all of this is, what does the patient want? What is their wish? What is their desire? If they don't want anything, then there's nothing to be done. We just go straight forward for whatever appropriate treatment will be given. But once a choice has been made, we need to decide that, would it work for you? Would it work for your body size, your body habitus, and even what the disease is doing to the body? Would it work? And in some cases, well, in many cases, the ladies come along with their partners, their husbands, to have this discussion, because it's as has been said in previous presentations, it's not just about one person. It's a whole family affair. or a society affair. Whichever society you're part of, it's important. Next slide. So we would never say that nobody can have, no one at all can have, there's no absolute contraindication to not having breast reconstruction. We have to marry a number of factors, as highlighted in the previous slide, to decide would this work or not. There are some big factors which supersede a lot of others, and one of them is smoking. Fortunately, this environment, we're not big on smoking, so it doesn't usually come up. But in some jurisdictions, it's a big deal. The smoking has significant effects on the blood vessels, which can really affect the outcome. Obesity is there, and that's it's a variable, a relative contraindication. So depending on your size, we may be able to use one method over the other. So you may desire to use, let's say, your lower belly fat for us to use it, but in some cases, even though you would assume that you have an abundance of it available, using it can cause quite significant complications, and therefore we would not want to go there. Next one, next slide. So with some types of breast reconstruction, we take one part of the body and use it on another, whereas in some cases we actually just use a breast implant, a silicone breast implant. Your ability to accommodate some of these would vary depending on your body habitus. So for donor sites, do you have an ideal donor site? I just spoke about your lower belly fat, whether it would be appropriate or not. In some cases, you may want your lower belly fat to be used, but it might actually not be enough or not be appropriate. You may have had previous surgeries which do not make it an ideal site. Some ladies will just say, well, whatever you do, do it for me. I just don't want any foreign body in me. I don't want any silicone in me. So we'd have to think of some ingenious ways to try and do some of these things. What is available to do? So logistics, you realize one of the first ones I've put up there is availability of radiotherapy services. Because ideally, if we're doing some breast conserving oncoplastic technique where we don't take off all the breast, we should have radiotherapy services available to complete the treatment. Theater space. These things take time. I'm sure if you ask the general surgeon, they'll tell you, oh, they can do a mastectomy in what? 1.5 hours, 1 hour, 2 hours. What is it? 2 hours. Okay. Some of these procedures can take, I'll choose my words carefully, as little as 3 to 4 hours and as much as 12 hours. Okay, so you can imagine the number of cases that could have been done while you've occupied the theater to do just one case. Okay, we in some jurisdictions they have the luxury of theater space and time. We are not there yet, but I think we're trying. We're trying. Okay. And then of course, if we are using implants, do we have them available? That's another big question. Fortunately, we've made arrangements to try and make them relatively available in a good range. So whatever type and size we want, we can get. All right. So within plastic surgery, these are the different services that we offer in relation to breast cancer. The first one says oncoplastic breast conserving surgery, which I've described. Breast reconstruction after mastectomy, where we use a part of your body or an implant. Unfortunately, not all our patients come early enough for us to be able to do some of these things, and we require chest wall reconstruction. That basically means that once the breast has been taken off, because of the size of the defect, because of the size of the tumor, you're unable to stitch the two edges together. So you're left with a big hole. So we need to find tissue or flesh from some other part of the body to patch and to cover up. Okay. Auxiliary procedures. Auxiliary procedures means additional stuff we do, not directly related to the breast cancer, but as part of the general treatment, which may range from reducing the other breast to creating a new nipple. Next slide. Forward, yes. So with oncoplastic, breast conserving surgery. What's the big deal? I mean, after all, we're only taking a small part of the breast off. I mean, won't it look normal? So depending on the amount they're taking off. So if we're taking up to between 20 and 25% of the breast off, there will be a significant deformity. And depending on the size of the breast, we use different techniques to fill it in or move things around. So there's two fancy phrases there: volume displacement versus volume replacement. So with volume displacement, it means we are able to reorganize the breast tissue to try and make it look normal, as against volume replacement, where the amount taken, we cannot reorganize what is left to make it look appreciable, and therefore we need to replace the tissue that has been taken away with something else. Next slide. So volume displacement, I've already described what it is, and it often results in a smaller breast. That's one thing, that's one compromise our women would need to accept. Many of us are blessed with a significantly larger bust size than in some parts of the world, and many people don't want to lose it, but unfortunately sometimes it's a compromise that needs to be made. Next slide. So this picture just shows different ways when, depending on where the tumor is, once it's excised, how we move the tissues around, the flesh around the breast to try and make it still look like a breast. Next one. So here's an example of a young lady. She was in her mid-30s who had a tumor where the white mark is, and she didn't want a mastectomy. Fortunately, the tumor size wasn't too big that we'd insist that she needed it, and therefore we do an oncoplastic procedure where we do volume displacement. So we move the breast tissues around to make it look normal. We told her that the amount we're taking out will make it a bit smaller than the other breast. We did the markings and everything, but at the last minute she decided she doesn't want us to touch the other breast. She's happy with whatever we'll do. So you can see the results on the top left, your top right picture, and the size difference isn't too bad, and in close she looks normal. Next slide. So this is another young lady. This was not a cancer, but she did have a large breast tumor in, if you're looking at her, so in her right breast, I'd say the right half of the right breast. So what we did is we designed it in such a way that once the tumor was taken out, because it was a sizable, the result would not leave her with significantly asymmetrical breasts. So what you see on the other side is the procedure that's been done. And to make you see how significant it is if you look at her nipples in both pictures and compare it to the position of her belly button, then you'd appreciate how much we've taken off and how much has actually changed. All right. Next slide. So volume replacement. So we've taken something out and we need to replace. Pretty straightforward. Next slide. So there are all sorts of fancy things that are available to do this, but not all of them are appropriate. So it all varies on the person we're dealing with. So this picture just shows different areas where we can take flesh and tissues out to replace the volume that has been removed, since it would, a straightforward closure wouldn't work, and removing the tissues around would make the breast look too small. Next slide. So here's an example of one where we had a tumor in the upper outer quadrant of the left breast. We ideally wanted this patient to have a mastectomy, but she refused and insisted that she wanted us to think of a way to replace the volume. So we did something called a latissimus dorsi flap, which is taking muscle, fat, and skin from the back muscle, and finding a way of swinging it around and tunneling it into the space. So you can realize that even though the left breast looks a little bit smaller, in a bra and in her clothes she would look normal. I spoke about the donor site, where we're taking the tissues and flesh from, whether it's acceptable to the patient and whether it won't cause too much trouble. Taking that muscle is fine. It does affect a few activities, such as if you are an Olympic swimmer, you don't want this procedure done. And you can see the scar on her back. We've tried to hide it as much as possible, but this is the result of latissimus dorsi for volume replacement. Next slide. So move to breast reconstruction. Next slide. After mastectomy. So once again, we know the general aims, and I mentioned that there are 3 methods: either an implant-based reconstruction, autologous, meaning your own tissue, or a combination of both. Next slide. So within implants, the silicone breast implants, we have different types and use them in different ways, but all in the light of achieving a new breast mount. Now, in cases where a lot of skin is taken away, as in a traditional mastectomy, the pocket where we would put in the silicone implant is significantly reduced because skin has been taken away. So we need to produce more skin. So how do we get that? We use something called a tissue expander, which is a type of silicone implant, but when it comes, it's flat. You put it into the space and then close everything up. And then on outpatient basis, the patient comes for a regular clinic. You inject through the skin into the implant and inflate it with fluid, and it gradually grows. So just imagine your pregnancy growing week after week. Your breast space will grow week after week. All right. As against a single regular permanent implant where no side effects of, okay, I'm being told my time is almost up, so let me rush through, and then after we'll take questions. So as against a permanent implant, which is full of silicone, and that is nice and soft, unlike the hard tissue expander, which must be hard to enable the skin to be stretched. Next one. Next slide. Okay, so this is an operative view. So the top left picture, the mastectomy has been done. Usually the breast sits on top of your pec major muscle, your chest muscle. So once the breast is off, it exposes the muscle. We put that particular special type underneath the muscle, and that's in the top left picture. Your top right picture for you shows the implant under the muscle, and then bottom left shows we've closed everything up, and then bottom right shows us inflating a little bit of fluid in theater. Okay. Once, give or take 5 to 7 days, she will go home and then come back on outpatient basis. Walk into the clinic, lie on a couch. We inject through the skin into the implant, push in the fluid, finish, and then you go home. Come back next week and we continue. All right. Next one. Next picture. So this is a lady, actually a very young lady. You can see from her tummy that she doesn't have much available to do a reconstruction from that. Likewise on her back, her only option was implants. She was 26, just finished national service, and so it was a big deal for her. So the picture, it may be difficult for you to see, but the picture on your left, we have a tissue expander. So she started off with a flat chest on that side. We gradually inflated, it stretched the skin, and to be able to stretch the skin, it must be hard to push. That's done the natural consistency of a breast. It should be nice and soft. So then after a while, we switched to the permanent implant, which we've done so on the other side, which is much softer. Now this is quite early post-op, so it will relax a bit and droop a little and look more natural. In this case, we had to adjust the other breast to be able to make it look more symmetrical. We did actually go on to do a nipple for her as well. All right. Okay. Next slide. You will see one. So once again, this is a lady who had a tumor which we describe as a phylloides. It also had to result in a mastectomy, and you see the flat chest and the expansion that has gone on to match the regular breast size. Okay. Next one. So this title of this slide is a one-stage implant reconstruction. Now, you realize in the previous ones, I talked about using a tissue expander to stretch the skin and then replacing it later with a permanent soft silicone implant. So in some cases where the patient would ideally only need a wide local Some of them, for different reasons, would come and insist that, well, if you're taking this breast off, I think I want the other one off as well, to try and reduce the chances of getting cancer on the other side. I've chosen my words very carefully, and I said reduce. I didn't say eliminate. All right. It's very important that they understand that. So for those who have a strong family history, some even do some genetic testing to see if there's a higher chance of them getting breast cancer, we go ahead and will agree to do this for them. So in this case, she had the cancer in her right breast. The plan was to do a mastectomy on the right side, and because of the size of the tumor, it was the appropriate size where we could do an immediate reconstruction with a soft silicone implant. Okay, so we went ahead to do that on the right. She also requested what we now call a risk-reducing mastectomy on the other side. Once again, please take note of my words: risk-reducing, not eliminating. Okay, risk-reducing on the other side. And then, so they've taken out all the breast tissue on that side, and we've also gone ahead to put in a silicone implant on that side. So the post-op picture you see, the side with the cancer, the nipple had to go because it was too close to the nipple, so there's no nipple on that side. But on the other side too, so now she has silicone implants on both sides, and that's the result. She has not yet come back for a nipple reconstruction, but maybe she's happy as she is. Okay, next picture, next one. So autologous basically means we use a part of your body to do the reconstruction. The different areas we use, they're all listed there, but there's some common ones that we tend to use. Next slide. Next slide. All right, so in this case, this lady came to us with a tumor in her left breast, and at the same time, she wanted a bit of a breast lift to match the other one. She initially told us she wanted to use her lower belly fat to do the reconstruction. She'd done a lot of reading, and she'd heard about it and wanted it to be used to get a nice flat tummy in addition. So if you look carefully, you will realize she has a surgical scar on the right side of her tummy, all right? That's called a coccus incision. She's had a cholecystectomy, an open cholecystectomy in the past, which is an absolute contraindication for me to use her tummy, which means, unfortunately, it won't survive. It won't do well if we attempt to do that. She was quite heavy, and so we were able to decide to use part of her back muscle, her latissimus dorsi. So that's exactly what was done. So we did a latissimus dorsi reconstruction on the cancer side, and we did a breast reduction on the non-cancer side, and that's the result. Next one. So in cases where we do use the tummy, what has been outlined down there is what we use. So we take that, in this case, with the skin, fat, and a bit of the muscle, which has the blood supply in it, tunnel it under the skin, and bring it into the breast space. So that's the resultant you see there. And like I said, a lot of these breast reconstructions can't produce excessively large breasts. So we tend to have to do a reduction on the other side, which we've done. Okay, next one. Next one. All right, so this is another type, but I think I'll just skip these because it's similar to the previous one, and if questions come up, I can answer it. But this is a free flap. What you see is the skin and fat and a blood vessel that supplies all that skin and fat dangling from its pedicle. And what we do is, once we find that on the belly, we dissect it out, bring it up to the space where the mastectomy was done, look for the blood vessels, and connect the artery and vein so that it has a fresh blood supply and will survive. Okay. Next picture. Okay, so that's the blood vessel in the chest, and then we connect. We had a few skin issues with healing in this one, but then this is just to give you a general idea of how it works. Next one. Chest wall reconstruction. Next one. So we tend to do this for advanced tumors. Many years ago, I mean, the general surgeons will remember times when you will see someone with breast cancer and you describe it as not being operable. I cannot operate on you because if I take it off, I won't be able to close, I can't cover, and it becomes quite an issue. So with the ability of us to be able to move flesh around the body to cover some of these areas, we actually have a lower incidence of such, if I'm correct. You're laughing. All right. So we use different parts of the body still to do the same thing. It may not be a curative procedure, but at least it improves the quality of life at that stage of the cancer. Next one. So this is a lady who had a sarcoma, another type of tumor. Obviously, if we take this thing off with a good margin of safety, the edges will be too wide for us to close. So in this case, we took the latissimus dorsi from her back, that's the flesh and skin and muscle, swung it round forward and used it to patch the area. And that's the post-op appearance. Next one. This is another one where this lady has already had a mastectomy. You can see the scar in the top left corner. It seems the history was a bit strange. It seems what was rather done was a wide local excision. I think she was advised to have a mastectomy and she refused. And someone did a very big wide local. So if you see a dark patch over there, it's actually a nipple. It's a leftover of the nipple. Unfortunately, the cancer recurred and the nodules in the skin. So what the line you see, the margin, is the excision we have to do to get rid of all of the disease. And of course, that leaves a dilemma of how do we close that defect, because there's nothing to move around to close. So we had to go to her back again and tunnel it forward and swing it round to be able to patch up, as has been done. Okay, next one. Another example, interestingly, this lady was a government official. I think she was a minister in one of the neighboring countries, and they didn't have access to radiotherapy, and so she came to Ghana for treatment and decided to have all treatment. Unfortunately, she came when the disease was already very advanced, and if they were to take off all of that, closure would be extremely difficult. So in this case, we did something called what we call an abdominal advancement flap. If you look carefully in this picture, focus on her tummy, and you see that her tummy looks like it has 2 chambers of, that's all her tummy fat. So we decided to use that and find a way of releasing it and bringing it up. So if you look in the final picture, she only has, if for want of a better word, 1 chamber of fat, unlike the previous one where she has 2. So we've mobilized that to help us close the defect. Remember, this is not a curative surgery. It's just to improve her quality of life while she's undergoing treatment. Next slide. Auxiliary procedures. Next slide. So, like I said, this is not directly related to the breast cancer, but we do it in addition just to make the quality of life better for the person. Next slide. So in this case, this lady had cancer on the left side, and the idea was to use her latissimus dorsi muscle. So if you look carefully, I've drawn in yellow, a yellow tip, and that shows the scapula, the back, the wing, what do I call it in layman's terms? A bone at the back of her on her left side. And I'm in black. I've outlined the muscle and the fat that I'm going to mobilize to swing forward to create a new breast for her. At the same time, we're going to reduce the other breast because we will not be able to get enough to to match the original size. Next slide. So that's the before and that's the after picture. The reduced breast and the reconstruction breast. So the skin envelope is full of the skin, fat and muscle from the back. And as the it consolidates itself, it will droop a bit and look much more like the other one. Once again, here I started the procedure of creating an areola for her, but up to date she hasn't come back for a nipple. So I'm assuming she's happy. So next slide, I'm almost done. So it's not every time we have to do something to create a new breast. So in this lady, she came and wanted the disease taken away as a mastectomy, but at the same time, you can see her pre-op size. She would be very lopsided and look very uneven in clothes. So she just wanted us to reduce the size of the other breast, which we went ahead to do without any form of reconstruction. So that's also a possibility. Next slide. I think this is my last slide. So nipple reconstruction. So this lady initially had a wide local excision for a benign tumor in her right breast. If you look towards the armpit, you realize there's a scar there. Then she came back later on with disease in the left breast, cancer in the left breast. So a mastectomy was done and we used implants to do the reconstruction. She then came back and said she wanted a nipple reconstruction done. So we had to raise the right breast, the one that had the previous scar, just to match the size of the reconstructed breast. And I've done a nipple reconstruction. So I've intentionally shown you the previous picture, the smaller one, to show that the healing process of the nipple, it's not fully healed. So you can see a little red patch of granulation of flesh that's still healing. And you can see the final result on the other, in the bigger picture. So I think that's my last slide. Next. Next slide. Okay, so we'll just quickly run through some figures. This is just to show that over the past 5 years, we've done about 184 of these procedures in Kolebu, along with the general surgeons. This just goes the breakdown for the statistics, left, right, those that were on both sides, those with implant-based or the own flesh. Next one. This just shows again the different types and different sources that we took the tissues from. Next one. These are the implant-based and the types and the number of procedures we've done. Next one. Complications. They will tell you that if you haven't had any complications, that means you haven't done enough of the procedure. So we always do tend to get complications, but we always tell you what is possible and how to will salvage it if it does happen. Next one. Okay, and these are complications for the when we use your body part to create the new breast. Next slide. So should we be doing more? I think we should. It's an integral part of the breast cancer care now, and we should not take it for granted. It's not a cosmetic procedure. Next one. There are a few factors that would limit us. The physician's expertise, how many plastic surgeons do we have who can do this? The hospital factors, the theater space, anesthesia, and of course cost. Next one. So this is an estimate of cost that we've done from Kolebu Teaching Hospital, and you realize there's NHIS, non-NHIS. Those issues have been explained already. I'm sure questions will come up on this later on. Next one. So in conclusion, next slide. We need to understand that it's not just about taking away the disease, but treating the persons physically and mentally, and this is all part of the procedure. And it's something that we should not just gloss over that, oh, this is nothing, forget about it. And it is something that should be offered to all patients if they come at the right stage at the right time. So the take-home message is that it's not the end of the story to say we're taking your breast off or we're deforming your breast. There are options, and I think the earlier you seek treatment, the easier the options and the more amenable they are to all of us. Thank you very much.
Okay. Yes, but because of time, we will take only 2 questions. Because we will go for break and then we come back. And also, all the email addresses of the presenters are in this, so you can always reach out to them. Yes. Yes, the 2 questions at the same time.
Yeah. My name is Anyoko Boate Amponsen. The first question is, I want to know, normally, as growing lady, the breast become hard. As you age, it comes a bit down. So what happens when you do the construction on one side? As you age, what happens to the other one? Is it going to happen that one will come down, then the other one will still be standing? and the side effect of the plastic surgery. Because most often, when you have a patient or you know somebody who has done it, then it can encourage you also to do it. But most of it, we don't see an example so that we can also try and do ours.
Thank you very much. Very informative presentation. Thanks a lot for that. You kept mentioning saline implants. How about, oh, sorry, you kept mentioning silicone implants. How about saline implants? Are they available in Ghana? And does NHIA pay for the symmetry, the procedure for symmetry when you do breast conservation? Thank you.
All right. So we gave room for two questions for now. When we come back, then we pick some more questions.
Okay, so I'll go in reverse. So NHIS does not pay for the implants. You also asked about the symmetrizing procedures. So the elements of the surgery that NHIS takes for is some key aspects of in-theater service. Okay. So if we're doing a combined procedure with the general surgeons at the same time, without implants, the only additional input is maybe extra theater blades, extra suturing, sutures and things like that, and extra anesthesia time. There's no extra hardware that's required, no extra consumables that would not be factored into a regular mastectomy. And therefore, a majority of it would be covered according to whatever ratio is pay or co-pay. I hope that answers the question. So you realize that when I put up the figures about the cost of mastectomy, I showed one without NHIA and with NHIA. So it doesn't cover everything. But if we're doing the procedure at the same time, it would cover some part of what we are doing along with the mastectomy. Okay. I do not use saline implants. The silicone are much more predictable for me, and with my training and all my exposure, it's always been silicone implants. So that's why I've stuck to that. Okay. They are not available in Ghana unless you order them yourself. I order mine directly from the companies in South Africa. So that's why I get these ones. I have not made an attempt to look for saline implants. Okay. The other question, the other half of the question was on size, ptosis. What we describe as ptosis or droopy breast, or what some would describe as Bobby stand. So you're right. As you grow, it does drop. If we use what I described as autologous, some part of your body, the match tends to be much, much better. So if you put on weight and your breast gets bigger, the reconstructed breast, which is also part of your own fat, would also get bigger and grow. If you lose weight, likewise. Okay. The implants is an inanimate object. It does not grow. It stays the same. So however we recreate the breast, it tends to stay the same. Okay. The issue with that is sometimes when there's a lot of your own flesh or skin around the implant, that will tend to grow and be affected to aging changes. So that breast will start to look different. Okay. Now the issue is how much different will it look? I can't tell, because it varies depending on how you would grow, how you would change. And therefore, the companies tend to tell you that the older generation of implants, I think that was the 4th generation, they were talking about its lifespan being about 10 years. Because of the way they are and the way they conform, after about 10 years, they tend not to look so correct anymore. The newer ones, they say 15 to 20 years. So that's what it is. And we tell them that that's the difference. And that's the reason why using your body part is actually the gold standard for breast reconstruction. Okay. The filling. Which filling? Sensation on the skin. So there are different types of sensation in the breast. Okay. So the sensation you get around the nipple is different from the sensation you get on the surrounding skin. Okay. The nipple is gone. So whatever sensation you had in the nipple previously is gone. Even if I create a new nipple, it is from the skin that is left behind that I'm creating a new nipple. So it would feel like the way somebody just strokes your skin the same way, not the nipple kind of sensation. The surrounding areas of the breast will still feel the same. Have I answered that question? All right. So the answer is no. So what we do sometimes with some of these free flap tissue transfers I was talking about is that we take, sometimes in addition to that artery and vein you saw dangling, we take a nerve as well. So when we get to the chest, we connect the nerve. But that only improves the skin sensation. It doesn't actually give the nipple sensation. The nerve ending types for the nipple are gone with the mastectomy, is gone. Okay, so we can't recreate that.
Yeah, thank you. We know there are a lot of questions. So as we are having our break, you can corner him and all those who have private questions can ask. And then we'll try and find time after everything for general questions which we need to answer. We'll try and find time for that. So we are not going for coffee break. As you can see, we are almost 1 hour behind time. So let's try and do it in 25 minutes. The coffee break is in the courtyard. So you pass through the black door, go to the courtyard, and it's there. So let's do our interactions there and be back in 25 minutes time so we can start the next session. Thank you very much.